All right, so good afternoon, everyone. So maybe we can get started. So I know that there's a strike going on, some activity going on campus, so we might still have some folks joining us. But in the interest of time, I wanted to get started. And first off, good afternoon, everyone, and thank you for joining us in person and also online. My name is Jay Lee. I have the privilege of co-leading the Health Equity and Translational Social Science research team here at David Geffen School of Medicine, along with my colleague, Dr. Alma Guerrero. And it is my privilege to welcome you to this event and also introduce our distinguished speaker. Just wanted to share some personal connection. So I totally believe that we're all shaped by the people that we meet along the way in our lifetime. And my personal connection to Dr. Karen Scott began when we were invited to for Meharry School of Global Health to contribute to a chapter called Intersectional Drivers of Mental Health Inequities. And that's the space I got to know Karen. And since that time, I've really, really appreciated her incredible work, her passion, dedication, and commitment to addressing really complex issues in health equity, and really left a lasting impression on me. And I thought this would be a really wonderful space for her to really share her work and her vision. So I have the formal introduction here. Dr. Karen A. Scott, she, her, proudly stands as the Chief Black Feminist Physician Scientist, founding CEO and owner of Birthing Cultural Rigor, LLC, boasting a remarkable legacy of service, leadership, teaching, mentorship, collaborations, activism, and advocacy in sexual, reproductive, and perinatal health, rights, justice, and liberation spanning over 25 years. Dr. Scott's unwavering commitment to transparency, truth-telling, trust, and transformation unveils a critical exploration of health services, design, provision, evaluation, and training in obstetric units as arenas perpetuating obstetric racism against Black women, girls, and gender-expansive individuals, but with the power and potential to better serve, protect, and care for our Black communities with dignity and grace. And it is a great honor for me to introduce you to Dr. Karen A. Scott, so please join me in welcoming her.
Hello, everyone. Thank you, Jay Lucy, the UCLA CTSI team, and people in the audience, online and in person. Thank you for choosing to be with us today, and those who have the desire but cannot, hopefully you'll be able to get access to the recording. So I really would like to have a conversation more with you. So we're going to do that, as well as I attempt to share a cogent narrative of my scholarship and activism really since 2018 to the present. And it actually started in California. So a lot of my groundbreaking work is because of folks in LA and Oakland who some of my community partners are in the audience here today, Dr. Melissa Franklin, and some are online. And so I hope that you can walk away with the desire, but also with more of the confidence and clarity and comfort to reimagine what equality and safety means with obstetrics and perinatal health as like the exemplar. So that's what we're gonna do. Please know we're gonna have a Q&A afterwards, but I really would like to get through this journey. And if when Lucy stands and lets me know, then I'll figure out how to get to the end, but we can also talk more during Q&A. So today, for the first time, I'm really, like I said, bringing together 6 years of work to demonstrate how I have been mobilizing a new obstetric quality and patient safety paradigm, the sacred birth framework, where every letter in the word sacred represents a patient-identified domain name and its corresponding meaning, manifestations, and measures for how to hold systems accountable really for what it means to feel safe, as opposed to standards of quality where it's about being safe. If you don't get anything else today, that's really the crux of my work, is to interrogate how we prioritize being safe over feeling safe, and how I have been able to translate anthropological theories of Donna Ayn Davis, my homie, her obstetric racism analytic and phenomenon into an obstetric quality framework, sacred birth, but as well as translating that theory that developed with communities here in Oakland and Los Angeles into a measure, the first and only patient-reported experience measure of obstetric racism. So at the end of this presentation, I would hope that you'll be able to complete these actions, right? But really through the application of health equity to addressing what I call the manufactured Black maternal health crisis, using my scholarship and activism as a case study. So hopefully you'll be able to define the limits in the existing obstetric quality and patient safety paradigm, explain the difference between being safe versus feeling safe, name, not define, just name at least 2 Black women defined theoretical frameworks to contextualize this manufactured Black maternal health crisis, and then list at least 1 application of the sacred birth framework and the PRIM-OB scale suite respectfully in an improvement or implementation initiative to address obstetric racism and to advance obstetric patient safety. Yes, I'm all the things, thank you, Jay, that he described. And it is just really an honor that we've gone from today to when we met online to writing a chapter and Jay saying, I would love for you to be here at UCLA. So it's been in the works for like 10 months or so. So thank you. I am a Southern Black woman from East Nashville before gentrification. I am the daughter of Edith W. Floyd from Tennessee and the late John Henry Scott Sr. from South Carolina. I am really grateful for the gift of the liberal arts education from the 5th grade, actually through the completion of medical school. In medical school, we went to school at Case Western for 4 hours out the day. Our afternoons were free and we could take courses anywhere within the entire institution. So I really am a liberal arts scholar, a lifelong learner. This is the way, if you know where that comes from. You also know I'm a Trekkie and Star Wars person as well. I'm a proud Black feminist, reproductive justice avenger, a Wakanda healer, Yoda follower. I am a Care Bear hugger. So when you come up to me, I'm always like, can I hug you? One thing that I don't always tell people, so in the church I used to go to in Chicago, literally I was on the hugs ministry. That's not what it was called. It was called the greeters ministry, but I literally stood outside waiting for people to come in. This is of course pre-COVID, right? Just hugging people because you never know, right? In any moment where just embracing and affirming, right, someone's humanity can really change how they see themselves, but how they see themselves in the world around them. And so again, part of why I am so assertive in the work that I do is really trying to restore humanity in health and human services. That's also another thing. If you don't get anything else, is how can we restore humanity and curate spaces of really caring for people in healthcare and not degrading, dehumanizing, alienating them. This is a 21st anniversary, maybe. It's 22nd anniversary of me being a community-based trained serving OBGYN. And again, my purpose is to advance cultural rigor, which is how I combine NIH's scientific rigor with cultural humility defined by Dr. Jan Murray Garcia, and Melanie Turbalon, again, 2 Black women pediatrician public health scholars from Oakland. So I am very much grounded in the California Black women's scholarship and community and in academia. And so by operationalizing Black women defined theories and also a non-Black woman theory of Black feminism, RJ, and research justice, I operationalize cultural rigor in 4 modalities: as a framework, as a vision, as a praxis, and as a movement in quality improvement and implementation science, practice, research, and interprofessional education and training. So I start off my talks in this way because I do everything to avoid what I call disparity data porn. So you're probably used to people saying Black women are, 3 to the time is blah, 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 blah. Health equity actually would have us reframe that statement and say hospitals are 3 to 4 times more likely to kill Black women, but we know we don't say it that way. So when we look at what the data says, we really should be starting with the system and the structure and not ways that reproduce mother blame or reinforce biological like inferiority, inadequacy, or determinism. So the data that came out this year showed that discrimination was a factor in 30% of pregnancy-related deaths in 2020 across 38 US states, based on 523 of 525 deaths. So again, a question that I'm hoping that you continue to think about is how are you measuring discrimination when it's a contributor to 1 in 3 pregnancy-related deaths, right? So I also want to then I invite you to consider the role of health equity in this work, right? So the definition of health equity that I use is a combination of what the CDC says, but really what Dr. Kamara Phyllis-Jones says, family physician, epidemiologist, and former past president of the American Public Health Association. Health equity is providing communities with opportunities, options, and resources to achieve the highest level of health for all people based on individual and community level needs, independent of their social, economic, demographic, or geographic circumstances. But I also like the bottom part. In 2014, Dr. Jones defined health equity as the assurance of optimal conditions for all people, a perpetual process whereby systems and structures are required to value everyone equally, rectify historic inequities, and distribute resources according to need. So based on, okay, I didn't know that was there. So based on that definition of health equity and the fact that we found that discrimination is a contributing factor in 30% of pregnancy-related deaths, you can say just off of that statistic alone, hospitals in the US do not routinely keep Black women, girls, and gender-expansive people and their loved ones safe or safer during pregnancy, labor, birth, and postpartum. And why would I say that? Well, again, on the right are these some statistics that I also like to bring up that usually don't get stated. So I also ask that we don't leave the 98 behind. You're like, who are the 98? Well, the 98 represents the 98% of people in this country who still birth in a hospital, either by choice, force, or coercion, right? And so all the wonderful things that we're doing, and I am happy National Midwifery Week, I need to say that. I am a midwiferized, dissident, and disruptive OBGYN. My chairs during my residency training program were the MD collaborators for the largest midwifery practice in Southside, Westside Chicago, Alivio. So as an intern, I was rotating a full rotation with midwives, being in the room, not doing anything, right? Because it's not about interventions, right? It's moving with people through their process, through their experience. And so I am so much for community birth, birthing at home, birthing in birthing centers. And the fastest growing group of people who are making that decision are Black women. We don't always say that. I think it's like 60-something% at a higher rate than any other racialized group. Everyone's moving, but that group is still in the 2%, right? So 98% of births occur in the hospital. And if we keep thinking more about those statistics, 84% of pregnancy-related deaths are preventable. So 98 are in the hospital, 84% are preventable, 84% preventable, then 88% of births are attended by physicians. And those people who are attended by physicians ended up leaving the hospital, but then we know that 53% of pregnancy-related deaths occur between postpartum day 1 and 365. So all the things that we are doing or we are claiming to do around addressing the Black maternal health crisis, we cannot leave the 98 behind. And we have to do more than redesign prenatal care, because that's not actually when we are dying. We are dying once we leave the hospital where in which we gave birth. So again, how does your organizational policies, practices, processes, procedures, your programs either align or misalign with this evidence-based definition of health equity, but also with these statistics that we have that we normally don't lead with? We usually lead with blaming Black women. And many of us do that look like me. And so these are different statistics that I would like to encourage you to use when you're talking about this work. And why is that important? Well, if we're going to solve the problem, we need to know how to actually define the problem. And one of the ways that we define and measure, right, progress is with numbers. We focus on outcomes. So I would like to tell you this one thing, and you don't need to really listen anything after this, honestly. A positive outcome is not a positive experience. And I'm going to say it again. A positive outcome cannot be conflated with a positive experience. Well, why would I say that? Well, look on the screen here. You'll see these are some standard outcomes that we use to evaluate the performance of a hospital. But if you look at those outcomes, they're really measuring the body. The BODY, specifically the Black reproducing body. They're actually not evaluating the performance of the hospital, but there are all a list of positive outcomes. We praise and give joy for full-term pregnancies, people who don't have any comorbidities, medical comorbidities, or social comorbidities. They have optimally utilized prenatal care. They started early. They went to all of their visits. They had a vaginal birth and perhaps just a small tear in the area in the vulvar area with the anatomy. They had a normal weight infant, a healthy infant who did not need to be admitted into the neonatal intensive care unit for little babes or to have special care nursery. They latched well to the body, breast, and chest. All of these positive outcomes can occur in Black women, and these hospitals and this care will be labeled high performing, high quality, and safe. But again, a positive outcome cannot be conflated with a positive experience. A positive outcome, right, is the highest level of health as defined by the health system. In any of these outcomes, do we know that's what Black, anybody really giving birth, but because my work focuses on Black women and girls and gender expansive people, you can apply this to any group that's giving birth. What role did community have in saying these were positive outcomes? And that these outcomes represented their experience navigating the health system. And the reason why I brought this up, because this was an actual Black woman in my research who had this beautiful, beautiful birth. Everybody's clapping. And then at the end, while the physician is doing the repair, she tells us in our focus group that last part. And this is kind of a paraphrase because the actual quote is in my book. I put that out there, please get in December. But what she says was, though he put me back together, I still don't feel whole. So you have positive outcomes and you have a Black woman not feeling whole, which means she feels less than whole. She feels degraded, dehumanized, dismissed, neglected, rejected, and all the things that don't make you feel whole. And we just saw Dr. Jones' definition of health equity, right? But we have these positive outcomes, but we have a negative experience. But what do we always look at when we're evaluating quality and safety? Clinical outcomes. So the point here is that you could have suboptimal conditions, right? You could have systems and structures that do not value a Black mother. You can have reinforcement of historic inequities where through society, centuries, we've been told we are less than. If you look at antebellum ideologies and practices, it was grounded on saying we were animals, right? We were subhuman or not human to justify the brutality of chattel slavery and all those things. So these are all the things that are happening according to this person saying, I don't feel whole. But then we're saying that was a positive outcome because the system said positive outcomes was being safe, not knowing what feeling safe or unsafe means. So you have for this particular Black mother and many Black mothers and birthing people, an erosion of health equity. You have a positive outcome plus a dehumanizing experience, which equals the being safe as the green light for the system. But it really should give us pause, the red light, really to stop, because you have a positive experience with a Black woman feeling unsafe. But how would any system know that if all you're doing is looking at those lists of positive outcomes? So I offer to you to consider that by tradition, right, the system's intention is to meet those clinical outcomes, those positive outcomes. But they're not really measuring the hospital performance. Those outcomes are really measuring how the body responds to being pregnant and then responds to either the poor or high quality care that they're given based on how they present in the hospital. So if someone comes to the hospital like here and leaves like here, either almost dead or dead, but that happened during the course of their care, how can we literally blame that individual? They don't come into the hospital saying, and I do make a joke about this, but when we do say Black women are more likely to fill in the blank with every horrific thing that happens, I say Black women don't go to the hospital, ordering a site of a hemorrhage, a blood clot, an ICU admission, and possibly death. But that is how that comes across when all that we do is say Black women are more likely to fill in the blank. We are not actually holding our systems accountable to the evidence-based definition of health equity, right? That says systems and structures value everyone equally, right? That we need to rectify historic inequities. We're not doing that. So the reality, right, is that the community impact of care is that you're really looking how that bodies, either you can call it weathering, you can call it Sojourner syndrome, right? You can call it misogynoir, the Black woman super schema, like all these theories. That's what really those clinical outcomes based on the Black reproducing body are showing you, is the Black reproducing body's resilience and resistance. Where do we actually see the hospital's performance? Which is why I go to the right side. My recommendation for being innovative and disruptive is we need experience measures to supplement outcome measures, right? So that we can actually evaluate the hospital's capacity to mistreat or treat Black mothers and birthing people. The end. I'm going to keep going, but that's literally the point of what I want you to get from this work and what I've been doing the last 6 years. So we have these lists of outcomes, right? Is this a safe or unsafe birth? When you have a positive outcome and a Black mother saying, though he put me back together, I still don't feel whole. Is this a safe or unsafe birth? What do you think? Right? So that's literally what my work does. And so I'm very honored to be working with nurse scholars, with anthropologists, so Dr. Audrey Linden, Dr. Donna Davis, Dr. Sharma, who's I believe they're family medicine at UCSF, and myself, we were able to, write this editorial justifying that emotional safety is patient safety. And it was published in BMJ Quality and Safety, which is huge because they're like the leading journal for evaluating it and disseminating information on safety and quality. And I remember Dr. Linden, of course, when I do the edits and Jay knows, I'm like, let's go there. 'Cause I really don't have anything else to lose. Like I became an OBGYN, not actually to be at the bedside. I thought they were the group that was, I'm giggling inside, that was going to transform healthcare delivery models. I did not know that's not what we don't do that. Some of us may do, but collectively, we're not trained to redefine what a healthcare system is. We maintain the health system. And I'm saying that as a OBGYN. And so to be able to call in, call out to say that if we were to use obstetric racism as an exemplar to show that systems prioritize being safe off of standards that actually really keep them safe and not really based on community wisdom, patient experiences of what it means to feel right in the hands of being either cared for or being uncared for, being neglected, having your care unfulfilled, delayed, or denied. So with that work, we talked about the consequences of prioritizing being safe over feeling safe. And because I want to keep going, again, if you don't remember anything else, these are 4 things, right, that can happen, 4 consequences if you prioritize being safe over feeling safe. Well, number one, you dismiss patients' testimonies, right? Like, and that comes into play around if you know about epistemic justice or hermeneutical injustice or testimonial injustice, which I have a slide on that. The thing is that we diminish the value of patients' words and feelings, even in the way that we document in a medical record. It's called a SOAP note. S is for subjective. Hear me out. O is objective. Who gets to be in the objective part? Me, physicians. And then so we're already in the way that we document and disseminate healthcare information, delineating between what's true and what's not true, what's credible and what's not credible. The subjective part is what the patient says. The objective part is what the clinician or healthcare professional thinks or does or uses tests and imaging studies. And I'm not negating the value of technology. I'm saying we have also someone in front of us telling us a story. Why do we already set it up to not believe them, right? And so then we displace the responsibility of perhaps not achieving health equity. We put that on the patient or the community because they're not telling us the truth or because they showed up in this way when we're really supposed to be meeting people where they are according to what health equity is. So why, when I think about some of the Black mothers who talk about the masculine presenting partners of Black men have said they will show up to a birth in a suit and tie or in a polo and khakis, so that if they need to advocate on behalf of their partner, they are not seen as like the menace to society or as a threat, so that they don't get removed from the hospital room and then not even be there for their birth or to support their partner. Like these are all the things that we're doing to make the system feel safe. At the erasure, the erasure and exclusion of our own safety, we're doing things to make it better for the system. And that is not the definition of Mara Jones health equity, right? It's systems and structures need to do X, Y, and Z, not the patients. And I'm not saying there isn't a thing as patient responsibility, but I'm saying that some things are happening because systems and structures are allowed to operate in the way they do. And one way to not hold the system accountable is to say clinical outcomes alone, claims data, is the only way to really evaluate quality and safety, or we will compensate right care. So imagine all those horrific things happening which will go through a story. But because there is no way for the patient to edit the health record, right, to share their own story, the outcomes don't reflect their experience. They were also compensating horrible care, or we're compensating health or inequitable health care because we were using systems of theories and measures and meanings that again diminish people's experiences and their feelings, right? So we downgrade what safety means by the patient, how they see it manifesting and how they would measure it, even how they would monitor it, which all goes back to our standards of safety theories and our domain names, their meanings, the way we see them manifesting, and then how we measure them actually reinforces epistemic injustice, right? It is tainting the knowledge that we think we know and the knowing that we're comfortable with around what quality is by just removing the entire patient in it. So this article came out the first day of Black Maternal Health Week this year, April the 11th. And I forget the number of the hospitals, but can you imagine the work that I do, right? And I'm waking up to someone had the audacity to say, here are the best US hospitals in the country. Now, again, what I just shared with you, right? And look what this says, with excellent patient outcomes. What is your first response? Now that I just gave you what the really meat of my work, when you see this article, what is the validity, right? What's the integrity of the data informing this list based on excellent patient outcomes? I mean, you can tell me when you see that, what do you think? Bingo. Right. That's the biggest thing. Like, we have standards of care, we have safety measures, we have list rankings of best performing hospitals. They didn't talk to one patient. It's in the article, not one patient, but it came out in US News and World Report on the first day of Black Maternal Health Week. So again, another point of mine, we must call out the lie. I do say things that get me in trouble, but we must call out the lie and quality improvement. And the lie is that the absence of perinatal pathology is the presence of perinatal equity. Going back to Dr. Jones' definition of health equity, can we safely assume there is equity if we're only looking at clinical outcomes? And we have people saying how they just feel like unloved. When we get to my framework, safety really came out and talking to the 36 Black women from LA and in Oakland. Thank you, Black Women for Wellness in LA, and African American Breastfeeding Cultural Outreach Task Force, BCOT. When I started this work, January 2019, safety to them really meant feeling loved. And I was just like, well, tell me what that looks like, right? Like, you're telling me what it means, what safety means. Now tell me, what does that look like in a clinician's attitude, in their behavior, in their language, and a hospital's policy or practice, right? I know we did a lot of things during COVID 2020 for mitigation strategies, but how well or how poorly did when we think about what we did to mitigate the spread, right, of COVID and the severity of like disease progression and deaths by limiting the number of visitors in a hospital, I understood the science behind that. But the humanity part said how many individuals and families birthing actually died or were harmed because we removed their shield of protection. Because we focus on the safety of the system. And I'm not saying these things are wrong. I'm just giving you an opportunity, right, to interrogate the consequences, right, of prioritizing being safe and the system's safety over what it feels like to be the patient in the system. But I would also add being the hospital or the health worker, right, attempting to stand up for justice for the families and what we go through, right, when we comply with keeping the system safe over the patient's safety. So how do Black mothers and birthing people feel in our care? What happens when standards of safety violate evidence-based standards of health equity? So these are just questions. Again, just because you don't see the pathology that you define doesn't mean someone's not being hurt or harmed. So here's a narrative that I'd like for you to listen to. And then I will go from this narrative to just the names of my framework, and then show you an example of how the framework is used to analyze a narrative, but also how you can use the scores from the scale to compare the systems. Because again, the R word, racism, is a trigger word for many people, but this scale actually allows for us to evaluate hospital performance based on the experiences of what it means to be both Black and a person with reproductive capability, which really no other thing does that. So here's a narrative from 2020.
The biggest issue I had with my labor and delivery experience is the fact that I developed a birthing plan in writing prior to delivery that was in my chart regarding pain control, yet it was not honored. I expressed my need and want for an epidural to anyone who would listen. They cared for me during my time at the hospital, yet somehow I was forced to deliver naturally without any pain medication. This was not because I had a quick labor either. I got to the hospital at 7 p.m. They started my induction at about 10 p.m., and I did not deliver until 6:06 a.m. So they had ample amount of time to fulfill my need for an epidural. There was a point where my husband was asleep, and I could not yell loud enough to wake him due to the amount of pain I was in, but I could reach the nurse's button, but nobody would respond. I felt like I was in pure hell, and it was the worst, most painful, most traumatic experience I had to endure when it comes to labor and delivery, and this is my fourth child.
So this Black woman, fourth child, fourth vaginal birth, I mean, right, would meet all that criteria of a positive outcome, but listen to her story. So we are actually failing our communities in advancing health equity when we choose now to intentionally ignore the experiences of care as a supplement to understanding outcomes, as a way to truly evaluate the hospital performance. By focusing only on clinical outcomes, we are actually choosing to not be transparent, right? To facilitate mistrust, to actually not be hospitals that are transformative, but are actually really harmful and reproducing historic inequities. Okay, I'm gonna finish in 8 minutes. So the gaps between health equity, right, and what I'm talking about, obstetric quality and patient safety paradigm, these are the gaps, right? They're ahistorical, they're atheoretical. We do have gatekeepers of data, information, and knowledge. We have, in terms of leadership, lack of demographic, experiential, epistemological diversity, right? We have centric goals and leadership and collaboration, prioritization of clinical only outcomes. We're not recognizing, right, contemporary workplace mistreatment, harm, violence, and oppression at the level of the patient, but also the hospital workers who are attempting to kind of stand in between this kind of duality of I work for the system, but I also come from the community, which is what I navigate, right? Being the oppressor and also from the oppressed community and what that feels like. These are just examples of that. We talked a little bit about how the consequences of what we're doing, right? It creates this epistemic redlining, right? This hidden ranking system of whose scholarship, whose knowing, whose knowledge is seen as of value, who gets more visibility. Then it allows us to discredit Black women, their voices, their narratives, their lived experiences, leading to epistemic injustice. It also then leads to hermeneutical injustice, where as a whole group, right, of people, they're seen as being incapable of making sense of their own stories because we tell them it's not right because at least you survived. That's what we're telling people. So you're having people to rethink that the harm that I feel isn't real because I survived. You can still survive your birth and still be treated horribly. But we focus on clinical outcomes, right? So we don't really get to know the experience of the horror because we focus on the outcome that the system picked. So again, doing all of those things, right, leads to the hypervisibility of Black women as victims. Black women are more likely to fill in the blank as a victim, as opposed to the patient content community expert, right? The structural exclusion and racial Black women as different levels of expertise. And we get into this space in community and in academia and government and industry where we have this control, constraint, and censorship of Black women's narratives and their intellectual thoughts. So when I bring to QI, right? Is seeing Black mothers and birthing people, Black community leaders, women activists, artists, Black women scholars, and ally scholars, where our common expertise and experience was public health. It brought us all together. We have this shift in power from those who are controlling what the standards of safety are to those who are navigating what it means to be unsafe, but no one's capturing, I want to say no one, let me phrase it. The systems that control what gets defined as safe have not been as open to the other side of that story. So name the phenomenon. Racism, I said it. Obstetric racism, to be specific, is what I study. Define the phenomenon. I use Black women centered frameworks of like liberation, emancipation, of justice, and then propose the methods to measure, monitor, and modify that. So I worked with Black women-led serving community-based organizations. I worked with a transdisciplinary team of Black women scholars and ally scholars. We developed the measure. We also then utilized the theories from the framework to develop a protocol for eliciting information from Black community leaders here in California, 24 participants from 15 Black women-led organizations in California, where Dr. Melissa Franklin was one of those, who we developed a virtual quality improvement prioritization of affected communities, where the community decided what the QI innovations were, and not one innovation focused on changing or blaming the patient, right? So that actually reproduced health equity. So cultural humility plus scientific rigor equals cultural rigor. The 7 pain points that I always talk about are the ethics, the knowledge, the science, the leadership, measurement selection, monitoring strategies, data quality and accessibility, and community participation and partnership. That's only at the bottom because it is the foundation. We should really have community engaged in all of those different 7 areas so that we can actually have both cultural humility and scientific rigor together in quality improvement and implementation science. Cultural rigor, again, I operationalize several Black women theories, but it is a movement because we're changing the way we think. We're using political activism, right, and participatory perinatal QI because we're shifting the power. It is a framework. I adapted Harriet Washington's medical apartheid into reproductive and perinatal apartheid, which may be heavy for people, but when you read my book, you'll understand why. Sojourner syndrome, Leith Mullins anthropology. We not only frame the problem based upon systems and structures, but we also need to highlight communities' resilience. We need to do them both. Because when you only focus on the death or near dying, then we may potentially see ourselves as less than because of what, not people in this room, but what the field could be disseminating around what's happening. It is a praxis, right? It is a behavior that we're committed to, and it is a vision, right? How do we mobilize a sacred birth movement and ending obstetric racism? That's the definition. We could go into it, but that's what I use. But the reason why we use obstetric racism, which does sit at the intersection of medical racism and obstetric violence, and really looks at the subordination of Black folks, right, in healthcare that is grounded in anti-Black racism and eugenics. Thank you, Dr. Diane Davis. Is because that's what people feel like. So when people are like, are you sure it's obstetric racism? I'm like, that's strong. And my colleagues in the Gray Journal, who you know who you are, you put out an article this year that came out the last day of Black Maternal Health Week that said obstetric violence was a misnomer. So you reproduce epistemic injustice, hermeneutic injustice, testimonial injustice by saying obstetric violence is a misnomer. But you did say you do harm people. So this Black woman said you push the baby out, then you go back on the fields and you keep picking the cotton. So if the community feels this way, then why are we not choosing theories, right, and measurements and monitoring strategies and mitigation strategies that reflect the experience of the community, not discounting the system, but we really should be looking at them both so that we can actually truly move towards what the precision and accuracy of health equity says and not just performing. So these are our truths. I am going to stop in like 60 seconds. I'm going to hope. Our truths. We believe, trust, value, and adore Black women, mothers, and people, gender expansive people. These are our ethics, right? Black women, people, and mothers, and gender expansive people are worthy. Right? We protect, prioritize, cite, and amplify Black women's, people's voices, intellectual thoughts, lived experiences, and political activism. We don't empower. We say we activate and advance. We say we affirm, we actualize, all of those words. The power and potential, not the pathology of Black people in this work. Sacred birth, the framework, kind of the bigger vision, it's a radical attitude towards human birth, specifically Blackness, Black bodies, and Black births that regards all birth activities as fundamentally normal, healthy, spiritual, familial, magical, transformative, erotic, communal, emancipatory, and power activating. It encourages diverse and inclusive birth pleasure practices, care, spaces, options, right? Some of these words sound like what's the definition of health equity? And it is a movement that advocates for safer, respectful, dignified, high-quality participatory birth care, conditions, experiences, and outcomes, as well as an overall improved workforce diversification, but also development and sustainability and restoration of Black midwifery care and Black dual support. So I look at the problem, the persistent near death and death gap. I have those Black women-based theories to help me contextualize the problem, but also to help me with the solution. And going from left to right, I go through this arc of cultural rigor, right, that operationalizes Black feminism, reproductive justice, and research justice to get a better sense of Black women's and people's expressions, expectations, and experiences of birthing in a hospital setting. And based upon what they shared with me, these are the domain names that came from their actual words. Like literally during the focus groups, a Black mother stood up and said, we usually are incapable of fully grasping what happens to us, right? Because we need to show up and be a parent or be a partner. But she's like, well, where's accountability? There's a difference between venting and reporting. So the word accountability came from a Black mother. It wasn't me. All these words came from Black mothers and birthing people: safety and accountability, autonomy, communication, information exchange, racism, specifically anti-Black racism and misogynoir, empathy and humanity, dignity and Blackness. These are the domains. Thank you to California, the 36 Black mothers and birthing people from February and March. February, we're in Oakland with BCOT. March, we were in Black Women for Wellness. And I essentially have told you all the things that we've done from our methods, right? We identified and defined a theory, we had a conceptual model. We looked at existing measures to see what mapped onto Black women's experiences, not what the system says is being safe. We designed new items. We did this whole banking system, looking at different populations, ethics, theory, knowledge, and the science, using patient content community experts, and then we tested that work. These are all the different groups that we use along the way. I call everyone an expert. This is another story that I won't.
Thank
But here is what we did, right? We translated a theory into a measure off of Donna Ian Davis's work. It's published. It's here. I want to say thank you again for the folks in California who helped us to get to having this scale that represents an additional 806 Black mothers and birthing people across 348 hospitals in 34 states. The scale is here. It went from 7 theorized domains, where 4 of the domains were in humanity, and then kinship and racism. No other quality instrument has these particular domains, right? So we really are looking at the experience of care. And it's a little off, but what we essentially did, I guess the more important one I want to show you is this survival thing. The hospital, we saw that when we looked at the scale, right, these experiences of humanity, kinship, and racism, that when survival was the goal of the hospital and a Black woman or person felt that way, you don't even need the scale. We already know that if a Black person feels that they should be grateful for surviving, they were 6 to 8 times more likely to experience these violations. Here's a narrative, and I just want to show you what we do. We take a narrative, and then we map the narrative onto the scale without even having to take the scale, right? So it's an interpretive tool. I'm gonna keep going. And then we can actually, this is in California. Again, to the left means less, to the right means more. And the center was the national kind of data, the mean. Everything to the left was a better performing hospital because they had the lowest scores in the kinship domain. That SNTH in green and purple were the safety net hospitals in San Francisco and Oakland. You know what they are, I don't have to name them, but they outperformed the academic institution in California, in San Francisco, I'm not gonna name them, they outdid the private hospital. So this scale allows you to compare hospital to hospital or hospital to county. Now I'm gonna end because I want you to ask me questions. And lastly, this is the other way because I wanted to make sure I got through my objectives. We asked these lovely people in the room, some of them could be online. This is Dr. Franklin there, if you see her. this is what community gave us, right? We worked with community partners here in California, 15 organizations, 24 people, and they identified 74 QI innovations and prioritized 44. And these are the top two. Not one of these talks about changing the individual, but it's about holding the system and the structure accountable. And I just want to say thank you. We have a summit next year. Please come to that. We are launching a online quality consultation service. If you want to learn more and your system may not be ready, you can individually come and work with me. We're offering discounts to the top 20 people who register today, not just today, but before February of next year, so that you can learn how to do the same thing using our tools. And thank you. Any questions or comments or thoughts? Oh,
Scotty, that was remarkable and so inspirational. Thank you so much. And I hope this is just the beginning of our ongoing discussion to really elevate this important work. So I have, and for those of you online, the recording will be available and we'll post it on our CTSI Distinguished Speaker Series website. So one question we have from the audience is, question for Dr. Scott: what opportunities are there to the accreditation, for example, JCO or funded quality measures, to patient experience as a point of accountability?
I know how I want to answer, but ask me again to make sure I'm going to answer the question. Repeat that. What are the...
So what opportunities are there to tie accreditation, for example, JCO or funded quality measures, to patient experience as a point of accountability?
Right. That is a great question. I think that's what we're trying to do. When I say we, other quality and patient safety professionals and organizations there's this movement towards patient-reported experience measures or patient-reported outcome measures, so PREMs and PROMs, as ways to supplement knowledge about hospital performance beyond claims data, which is usually based on, right, the ICD-10, so numbers, it's a numbers game, right? They look at ICD-10 codes for the procedure gets a number and the diagnosis gets a number, and they look at that claims data for reimbursement also to establish what's a high-performing hospital and if you should get reimbursement. I know I simplified that. I believe there's an opportunity, but we know that things take a long time. I can say that I personally told a very high leading person at CMS that it's their fault that we're here, because I was like, you have the power to deprioritize claims data. And their response 2 years ago, well, that's all we have. So I'm just letting you all know that people know about my work, and I do just like this, talk to them in this way because the data is here, right? I feel like it's a movement. We're gonna have to all, like, petitions and letters and talks and honestly pulling like the way that, Dr. Franklin's here. There are, like, what can we do locally? Like our public health departments, our health departments, and how they provide, like, licenses, right, to medical facilities. How can we bring awareness to those in leadership who have some say over accreditation or getting a license to exist, that this system is getting reimbursed for these procedures or care, but this is what the community is experiencing, right, through narratives or stories and mixed data, and just holding people accountable. Like this is just an exemplar, but we can apply this to really anything. Like when we think about, like, kidney disease, right? Like the whole, like, the race-based algorithms, even with the VBAC, right? Even I could talk about, like, the skin color with APGARs, like how many babies are in the NICU because they weren't pink enough. So there's different ways that we can possibly hold conversations or bring awareness to say that what is being done as a standard to evaluate quality and safety actually is creating a myopic view, and that we need to move beyond claims data and move and add, I should say, supplement PREMs and PROMs. But it's going to take time, because that's all, well, this the excuse, that's all we know. That's what I was told, that's what we do. I said, but you could literally create, like, a policy or standard, like, today. I think we should also go to our state legislators, right? The way there's legislation for, like, implicit bias training or for advancing the scope of care for midwives. What if there was, and I have some if you need some, I worked briefly with people in New Jersey to literally write a bill that would require all Medicaid births by Black people be evaluated with the Primo B scale. There's lots of ways to get to that place, but I think it's going to require like a movement of people coming together to bring awareness and speak to people in academia, community, government, and industry. Because right now, that's all we're still doing. We're still compensating healthcare off of claims data. I hope to answer that question.
Yeah, thank you so much. So I want to make sure that we have time for our in-person audience to ask questions. And there's one question in the Zoom space, and then I'll ask you, and then we hand the mic over to other people. So the Prem-OB tool scale, does it only work for Black birthing people, or can it be utilized for all people? For example, ethnic minority birthing folks?
That's a great question. I'm glad it was asked. So I utilize community-based participatory research like methodology, and also like critical, why am I blanking on it? Critical race public, you know what I'm talking, the anti-Black racist praxis with Chandra Ford and Eri Himbua. Is that critical public health race methodology? Thank you. So I did that. So the scale represents that experience. So what I'm saying is that we would need to, and I was talking to Jay about this, there would need to be a cross-cultural translation of the scale for other groups. It could possibly be more feasible if done with groups, right, that let's say they speak different languages or they come from different countries, but the experience of either chattel slavery and plantation colonialism, that is the basis of what this Primo-B scale does for Black folks. So we found that when we look at nativity, that foreign-born Black people are going to have lower scores of racism because that racism is grounded in like white supremacy in the United States, chattel slavery, but they have much higher scores in humanity because of their capacity to maintain social kinship, that they're more sensitive to disruptions in kinship as foreign-born Black people in how they perceive the harm than US-born Black people. I hope that is making sense. And so right now for validity, it works in Black communities, but there is an opportunity if someone wants to work with me to do a cross-cultural translation. I am thinking about that with Native people, which is why our summit next year is focusing on Black and Native youth, and also Spanish-speaking populations from communities like Puerto Rico, the Dominican, where chattel slavery was a part of that country's history. I hope that answered that question. That's saying it's possible, but we need to do it correctly.
New framework that ruler should be applied to any.
Yeah.
Otherwise, actually, discrimination. Black people against others, because the same standards apply for everyone, and not for Blacks to set up a specific criteria and that prioritize you with. It's unfair.
I hope I'm understanding what you're stating, so help me if I'm not. I hear you saying that, well, I don't want to put words in your mouth, that this scale was developed on the experiences of Black mothers and birthing people. The methodology can be applied to any racialized or ethnic group. The reason why it would not work per se in like, in an Asian population, because I don't know what the experiences are. So what I would say is that the way the system has imposed standards of safety on all people, right? That is discriminatory because we're not all experiencing the same thing. So my work decided to focus on one particular group that is marginalized and minoritized by the system. But I am inviting people to consider that this is like an exemplar. So what can we do to bring other structurally minoritized and marginalized experts as patients, as communities, content experts to do the same thing? There could be a Prem-OB scale for Native American people, for Hispanic people, for different populations within the Asian community, because we know there's diversity in people's humanity, but also in the harm. So what I offer is an example of how I did it for one particular group, and that it will serve as a model for people to replicate or adapt that methodology for any other group in this country, whether they are disabled, right? if they are from the LGBTQIA community, for adolescent population. So it's a model for this particular group, but the methodology could be applied to any group that's experiencing discrimination in the healthcare system. I hope that answered or supported what you were saying.
Yeah.
Oh, I was.
Oh, I just speak, oh, wow, this is different. So I really don't have a question, maybe. I just wanted to first thank you for taking the time to share your amazing work. I really enjoyed how you framed how we report statistics or even the state of Black maternal health being grounded in equity and how that does not harp on these negative statistics. So I'm often invited to speak to nursing students, medical students, and often asked about, oh, why didn't you have any statistics or why? And so the statistics that you presented are very helpful and not just ruminating on because to your point, I have many friends who identify as Black women who don't want to become pregnant because they're so afraid of what may happen if they do.
Yes.
And that's, yeah. So thank you.
Thank you, Dr. James. Thank you for saying that. And that is what what I offer to people and how I show up is literally a model. So the same way that someone could take these same statistics for any group that's being harmed, it's a model to still be like data driven, but also being very humane in the way that we disseminate the information. And again, putting the onus of the harm and mitigating harm on the system. So that's why I do what I do and I show up the way that I do when I don't lead with Black women are more likely to, because that condition has a name. Thank you, Dr. Art James, Papa Baba, for showing me. I think it's called tocophobia. I'm going to look it up. Is that correct? Yes. That there is a fear, right? And it hasn't been written about Black women. Hint, hint, Dr. James, if we want to do that with the other Dr. James. But yes, the decision not to parent is not actually fully autonomous, right? When we are making these decisions in a way because of fear. So that's really not allowing us to be autonomous agents in our capacity to build families. Thank you.
So Lucy, we have this room for a little one.
Yes.
So full disclosure, my vision is failing me. So I have
Oh.
my colleague here,
Mhm.
Dr. Erica Bath. She had a question.
Yes. I know I'm about to take my glasses off and do this. Oh wait, something disappeared. Okay, Dr. Bath. This is how I have to read it. Look, I wonder about expanding your framework to think about reproductive and sexual behavioral health education for Black girls and expansive birthing people, especially in the context, right, of Roe versus Wade / Dobbs. There have been negative impacts on accessing care and education. Yes. So you can, yes. So I have actually been doing that. Is it Dr.
Bath.
Bath? Dr. Bath, I'm so glad you asked that question. So if we move out of like obstetrics, like the birthing part, and focus on, I'm like everyone's name, Bailey, Dr. Moya Bailey's framework or concept of misogynoir, right? The vitriol. And again, I focus on Black women doesn't mean I can't do other things. I just don't know if I'll be good at them as well as other people could. So I do what I do. So when you think about misogyny or gender-based violence, and then you add an anti-Black framework to that, misogynoir, and then you add medical misogynoir. I have been dabbling in the sense of like, what does it look like to hold systems accountable for not reproducing medical misogynoir in the way that we, in these areas, interactions, communication, consent and refusal, informed consent, informed refusal, decision-making and documentation, dissemination of healthcare information in the health record and patient sign-offs and patient handouts. I think about this a lot. Actually, the training on that. And I'm gonna blank on the Black women nurses whose paper came out like in February or March, but they introduced a way of honoring Black women and Black women's decisions around their body and still being able to promote healthy sexual behavior, but doing it in a way that, right, that doesn't create harm by blaming someone, right? So they talk about moving from a risk-based approach where because you're Black and you're 18 to 35, or 18 to 25, and you're more likely to blah, 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 blah. It's called reason-based approach. Actually, the training on it, if anyone's interested, you can go online and download it. But I talk about that, for example, a Black woman coming in, I'm always going to do both, but they're pregnant. And the doctor says, oh, you need an HIV test because here's all the data. That happens. And in that published paper, they actually list language, right? Language that a clinician would use. And they talk about the harm of that. And they give you an alternative. So you go from a risk-based approach, which is grounded in the science. Yes, this particular group is at a higher risk for acquiring or spreading. We know that, but how can you reframe that in a way that still honors people's desire and their decision-making around seeking pleasure, and then invites them to be a partner in their healthcare? Like, how do we just be more mindful? But how do we be more mindful around what we say to patients to involve them in the healthcare? And so, yeah, I think that there are many applications of what I'm doing, not only in the research or QI or IS, but in just medical training, right? And just how we approach a patient and having a conversation around the body, right? Not just the reproducible, but just the body and what they do in, through, and with their body, and do it in a way that brings into context, right, history and contemporary implications, but again, like restoring the humanity in health and human services, and not doing it in a way that we stigmatize people for what happens either to them, through them, or with them, with their body. But yeah, but we can talk more. Yes, I have a whole thing on medical misogynoir and HIV. Yes. Hi.
Hi, Dr. Scott. Thank you so much for painting this landscape that you have. My specific question really is about the being safe is not
Yes.
equal to feeling safe. And I was thinking about how that might manifest at scale. And I wonder, and maybe you're already working on this, but I kind of hypothesize that the reverse equation is not true. Meaning, like, what I mean is, I bet feeling safe is equal to being safe. And I wonder if that's something you or anyone's already looking at, because that seems like that would be a way to connect the existing incentive structures that organizations have to pursue, sometimes, at least in the beginning, labor-intensive initiatives that are different than what they're used to doing to achieve an outcome they understand.
I'm with you on that. I just wasn't gonna say it because I feel like, it's like the ACA and Obamacare. I was talking to Jay, if you say Dr. Scott says it, maybe no one will follow it, but you said it. So yes, no, I'm being honest. Like, I think if we start with feeling safe, like as the grounding, and then work our way to like standards for the system of what being safe is, we're probably going to be in more alignment with what health equity looks and feels like, but also in just what a humane and just experience would be and feel like. But because we're starting with the system only, and it's not working, right? Standards of safety are not working because of the stats that I showed you. So evidence-based approaches should let us know the system's way of defining safety is making it unsafe for all of us. But we have people who won't let go. Power. But I do agree that if we were to ground ourselves in the experiences at like the patient, the community, the support, the community from which the patients come from, and how they are a buffer within the system and out the system, and then the system itself and those within the systems who come from the community that they see being harmed. I think if we thought about workplace safety in the concept of not just the Joint Commission stuff and the physical things, but literally what it means to be us in these systems, and started there, perhaps things could maybe, I think, change better for the better, and in a more, I actually think in a more rigorous, responsive, and relatable way. But I don't know where the we's are that are in those decision-making positions. But yeah, if we all focus on what feeling safe was like, especially for those on the margins, yes, I do think we would get to being safe. But we're not even doing the opposite. We're literally just doing, this is what being safe is. And I give you the example, one of the focus groups in San Francisco, I interviewed patients, then I interviewed community leaders and activists, and then I interviewed hospital workers. And I want you to just take a guess, all of you all. There was one strategy that these group of people, patients, community hospital, all recommended that would have actually advanced workplace safety for everybody, including the Black mother patient. It was one thing, and they all said it, right? And I was like, what? Childcare. The nurses were like, if we had childcare, we could focus more on being present for the patient if we had childcare. But then if you also had childcare for the mothers who are coming in with other children, who you then call CPS on, because there can be no unattended child on the floor. So we're like engaging family policing systems because the system says an unattended child is unsafe. But then you call CPS on the patient because you don't have childcare. And I was like, oh my God, like childcare would help to mitigate obstetrical racism, right? From the perspective of the patient, the community, and the hospital worker. Brilliant. But who's listening to that? So I honor what you're saying. And I think that is actually the way, because those nurses felt safer being a nurse because they could focus on the humanity of their patient and not on what their children were doing, because they're like, I'm working this shift. And then they could actually be patient with the patient to figure out, what are we going to do with your children right now? Because calling CPS is not an equitable reaction or response. So I feel you. I'm with you.
Hello, I'd like to thank you first for your talk today. I think it was really interesting that you introduced the idea of being safe versus feeling safe, especially because I do also like acknowledge that culture where we don't really recognize that like testimonial and emotional experiences are obviously validated that we should be considering. And so my question would be, I guess centered around people who are already working, I guess, for the system, but don't really want to contribute to that culture. Would you have any recommendations for people who are working in the hospital to kind of make sure that people feel like they're valued emotionally?
Thank you for sharing and asking a question. And I struggle because I'm looking for that answer too. I want to be optimistic, but I'm going to be a realist. It is difficult. I'll rephrase it. I think in order to, I'll use I statements. I am an OBGYN, US trained, US practicing. I don't feel safe being an OBGYN in the systems that I previously worked, but you can look at my CV and you can tell where I worked. The time where I felt safer doing this work, where I could speak out and up against what I saw happening, even that I contributed to, were in community hospitals or were safety net hospitals where the nurses and the physicians actually kind of grew up together. So where I trained, the nurses on the floor had 30+ years, but they were also the nurses that were with the physician attendings that were interns. So I saw people, and I'm not saying families are the solution, because I'm just saying that like it's something about connectedness and safety that people have through relationships that I think I saw nurses and physicians working together because they had a level of like dignity for each other and care and concern because their children played together, they worked together, they saw each other being trained. That helped me navigate that. But I also want to say finding mentors outside of the system in which you work. So though I still am a recovering OBGYN, I have found safety with people in human rights and legal studies and anthropology and social sciences and public health. I went and got a master's in public health and applied epidemiology. I started to look for my people, where I went beyond my field or my discipline and really looked at like values and I would say methodology. And I feel like my values and methodology for me being an OBGYN are much more aligned with ethicists, medical anthropologists, and human rights attorneys. I don't know if that helped, but like it's difficult. I don't want to discourage you from going into the health system, but I do think it's important to build a network of people beyond medicine, because we do have that's just how we're trained in this country. A myopic viewpoint of like what health is, right? Only 20% of healthcare contributes to health. There's a whole other 80% that do other things, but we prioritize healthcare, right? So you're gonna be surrounded by people who think healthcare is the only solution. It's not. And so I think for me, once I got into the public health world, I'm like, oh my God, these are my people. And it allowed me to show up with more hope in the healthcare system because I knew I also had like public health and FE and social sciences and activists, honestly, and artists. That was a long-winded answer, but I just say try to branch out beyond the systems in which you're seeing or experiencing the harm and work with them.
Thank you so much, Scott.
Thank you all. Thank you.